is a huge honor for me to be podcast interviewing a fantastic orthodontist, James Crouse from Salisbury, Maryland. He's an orthodontist, graduated at the University of Maryland Dental School, which I believe was the first dental school in the United States, right?
That's correct.
First one in the United States or first one in the world?
First in the world.
First in the world. He joined the Air Force after graduation and did a one-year GPR. The Air Force sponsored his orthodontic training at Emory University. Krauss moved back to his hometown after the Air Force, where he's been in private practice since 1994. He is board certified, and he has been an Invisalign provider since 2001 and is a top 1% provider with over 1,300 patients treated with Invisalign. And I wanted you to be on the show so bad because I know you're crushing it out there in Salisbury, but I have to tell you that we're about the same age. The only thing different is after I went to my dental school, they didn't close it down. After you went to Emory, they said that's enough.
Yeah,
And
pretty much, yeah.
Right when
one class after mine.
Right when James walked, it was the class after yours?
Yeah, in my orthodontic program. Yeah, there was one more orthodontic program class.
I'm surprised they don't open it back up. They've opened up 6 new dental schools in the last 10 years.
I know.
I'm surprised Emory doesn't open it back up.
I'm surprised too, myself, because they are opening another orthodontic program in Atlanta.
Is that right? Well,
Yeah.
you know, in my 30-year career, you know, when I became a dentist, you already had these big brand names that all the patients knew, like Crest and Colgate and Listerine. But I'd say Invisalign is the biggest consumer brand I've seen in my 30 years. I mean, it doesn't matter where you go. You know, the waitress asks, when she finds out you're a dentist, will ask about Invisalign. I mean, just an amazing brand. So what made you jump on it first? What made you jump on it and climb all the way to a top 1% provider?
That's a great question, Howard. When they first started out, a lot of my colleagues, we weren't real enthused about aligners, treatment with aligners. And a lot of, you know, the word spread around that go ahead and get certified, and then you can take advantage of Invisalign's marketing. And then they will steer people to you, and then you just tell them that they're not a candidate. And then you just put regular braces on them.
That's called bait and switch in MBA school.
Yeah, yes, exactly. So, you know, my turnaround came, I had an adult patient who had orthodontic treatment at a younger time. She had a little bit of relapse happen, and she wanted to correct this. So I figured this is a very simple, put partial brackets on her upper arch for about 6 months, and I'll be done. Well, 2 years later, I'm still messing around with this lady, trying to get her teeth straight and get her happy. So I said, let's try this Invisalign thing. And we did it. It worked great. And I said, you know, there's something to this. So, you know, I started doing more and more of it, took an awful lot of CE with, took pretty much everything that came around me from Invisalign and, you know, pushed the envelope, tried to do as much as I can. And now, you know, I offer it to everybody now.
So what percent of your patients get Invisalign versus fixed wires and brackets?
I'm up to about 60% now.
60%. Most of the orthodontists I talk to are about 20%.
Right. And I think that's more common. I think I'm kind of an outlier there.
So the average orthodontist I talk to says about 20% of their patients get Invisalign and the other 80% is fixed wire. You're 60%. Why do you think you're doing 3 times the amount of Invisalign?
I think it's because I'm willing to try anything. And I like the challenge of how can I fix this person's problem with Invisalign? And, you know, just because you're using Invisalign with somebody doesn't mean that's the only thing you can use. When we're using brackets and wires, we use elastics, we use, you know, lingual arches and TPAs and all kinds of things. It's not just strictly, you know, wires and brackets. So I kind of think of the Invisalign as the same way. If I need some type of auxiliary, I'm going to use it, you know, whether it's elastics or whether it's some partial brackets here and there. And to tell you the truth, the patients don't care if I have to put a few brackets, particularly in the back. It's still, to them, still not full braces.
Well, what do you think the advantages are? I mean, I would think home care would be a huge advantage. I mean, to be able to take them out, there's nothing worse than when you take out braces and to have demineralization around the brackets.
Yes, yeah, that's one of the things. Much easier to keep clean. The gums look a lot more healthy. And also, I like the control. The movements are more controlled. When we place traditional brackets and wires, everything starts moving, including the teeth that are in a good position. And I have more control over that with the Invisalign.
So you can just move one tooth.
Exactly. At least I know where the teeth are going. I don't have the unintended tooth movements that come, reciprocal movements and so forth.
Newton's law, for every force there's an equal and opposite force, right?
Exactly, yeah.
So what about compliance? How long do they need to wear these aligners a day? Some people say 22 hours a day, only take them out 2 hours a day. What do you think the hours of wearing need to be at?
I would love, that would be an excellent study. Of course, that's what Invisalign recommends. And I know it's probably rare that I get a patient that actually complies with that. I have an older lady that I'm just started treatment on now, and she is following that to the T. She's a rule follower. It says 22 hours. She's wearing it 22 hours. And she did, she let me know that it's a little difficult. So, it would be really a good study to see how many, what the threshold is. I imagine 20 hours is probably more realistic as far as what people are actually doing.
What about compliance? When you go with fixed, you're the boss. You're in control. Right. You glue this on. When you go with Invisalign, the patient is the boss. So how does that play into your head? What is the feedback on compliance?
Well, I tell people, a lot of people, I'm doing Invisalign on kids as young as 10 years old. And of course, people think, you can't do Invisalign on young kids because they're not going to wear them, right? Well, that's wrong. I think my younger patients are more compliant particularly than adults.
Really?
Adults. Yeah, because, adults say, well, I know he told me this, but, they're going to do what they want to do. Most of them, you know how they are.
I know.
They don't do what we tell them to do. They don't brush, right? They don't floss like they're supposed to. So at any rate, I tell people I wish I had some type of personality test that I could give to determine whether or not they're going to be good aligner wearers. As I said, I've got 10 and 11-year-olds that are awesome aligner wearers, and I have 40-year-old professionals that are terrible.
What about boy girl? It seems to me that women are just more motivated for anything beauty.
You would think so, but
is that not true? Is that not what you find?
I've got teenage boys that are great, and then I've got some nice young ladies that are terrible. So age, sex, it doesn't matter. Some of them are good at it, some of them aren't. It's just the person's personality.
Yeah. So also, what about young kids? It seems like so much of the young kids' love of orthodontics is all the different color rubber bands, and it's almost more of a fashion statement. I mean, some of them. I mean, they come in. They're coming in October just to get their rubber bands switched out to black and orange.
Black and orange, exactly. Yeah. Yes, I had some young people where they come in, they'd be a slam dunk Invisalign case. And the way I present my case is I tell the people, look, you can be treated with regular braces or Invisalign. Here are the pros and cons of each of them. And I'll tell them, with Invisalign, there's no eating restrictions. It's easy to keep your teeth clean. They don't make your teeth as sore. There's no emergencies. And I get done with all that stuff. And then they say, I want regular braces. And then I'll have the mom who's sitting there who had regular braces when she was young. And she's like incredulous, like, did you listen to any of the things Dr. Krauss just told you? And they're like, yeah, well, I want colors. And, if that's what their friends have, that's what they want.
It's so funny. One of the things that grinds my gears about economic data is how, they'll key in on one statistic and say, the middle class hasn't had an increase in earnings or money or whatever in the last 20, 30 years. But I mean, think about that. When you and I were little, if those big Catholic families where I grew up in Kansas, you had 7 kids. Only the girl who looked like she could eat corn on the cob through a chain link fence would get ortho. Nobody else would get ortho. And now all the kids get ortho. I mean, it's just like a rite of passage. Same thing with photography. I look at these selfies on iPhones, and when we were little, only the rich kid had the camera, could go buy the film, then take it, understand the camera, then pay to go get it developed, and you wouldn't see the picture for 2 weeks later. And now these people are posting more pictures of themselves on Facebook in a month than our kids did when we were in grammar school. You didn't take that many pictures in a year.
That's true.
So what percent of ortho is would you say is dental oral health related and just flat out cosmetic, hair, nails, teeth?
Yeah, that's a really good question. I think the majority of people that come to seek my care are coming because they want a nice looking smile. There's a small percentage that are coming, and they only want it if it's a necessity. Like they have to have it because it's going to affect their dental health. Very small number. Right. So would you say a dentist is almost orthodontist is almost like a plastic surgeon or a cosmetic dentist? We've gotten that way, yeah.
Yeah.
Although we do have a lot of health benefits to having our teeth straight. It's much nicer to restore teeth that are straight than it is that are all over the place. And we get the forces down the long axis of the teeth. I know one of our periodontists, she's very in tune to adverse forces on her on a lot of her patients.
So let's back up all the way. Let's go back 400 years ago. Why is it that 400 years ago, going all the way back to Lucy, 1,000,003, there's no malocclusions? I mean, everything is going fine. And then 400 years ago, it gets crazy, and now you go around the world, and it's all this malocclusion. What do you think's driving that? I mean, we always talk about how to fix the malocclusion, but it seems like no one's really talking about why did this not used to exist for the first 1.5 million years of sapien.
I don't know, Howard. That's a really good question too. Raymond Begg, the Australian orthodontist who developed the Begg appliance back in the 50s, he took out a lot of premolars, first premolars on practically all of his patients, and he looked at studied the Aborigines of Australia, and his theory is that their coarse diet wore the teeth down enough so that they didn't have a malocclusion. So what he was doing was removing 4 teeth to simulate that reduction in tooth mass. So I don't know how much of that is a factor or not.
That always made sense to me for the occlusal wear.
Yeah, but why would it have effect on interproximal?
Yeah, I never got that.
Yeah, I don't know. I have seen some people with really severe occlusal wear, some Korean wives when I was in the Air Force. There's one woman practically exposed the pulp on her first molars from the grit in her diet.
Well, that's why Dr. Park invented the Straumann implant in South Korea. He was absolutely convinced those implants were breaking. And when he would tell Noble Biocare and others, and they weren't listening to him. And he literally thinks and believes and proved that the Koreans have a much more harder bite than your Northern Europeans in Scandinavia. He finally said, "We need to make an implant for Koreans." I mean,
wow.
That was his
That's
whole,
fascinating.
Yeah, that was his whole genesis. He just said these Scandinavian people they don't understand Korean people. It's a different amount of he says different food, different chewing, different mastication. He says it's just entirely we need an entirely more dynamic, sturdy implant. And
interesting.
Yeah,
I believe it.
So one of the raps on one of the debates, I try to just talk about the on Dentistry Uncensored, not what anybody agrees on, what everybody disagrees on. A lot of people say Invisalign is for the easy cases, just some simple stuff. And
Sure.
it's not to be for the complex. How would you answer that?
Well, it's just a matter of knowing how to use the appliance, just like anything else. So I treat, as I said, I'll treat anything with the Invisalign appliance. I'll treat deep bites, open bites, class 2, class 3, extraction cases, impactions, narrow arches. Like I said, I look at it as a challenge, and the appliance is only getting better.
Could you do any orthodontic case with Invisalign?
I haven't run across one yet that I won't attempt.
Really? So you should be nominated for the poster child of Invisalign.
Maybe.
Now let's go to another controversial thing with specialist versus general family dentist. What are your thoughts when you see general dentist doing Invisalign? I mean, is it any different than when you see an endodontist see a general dentist doing a molar root canal, or an oral surgeon sees a general dentist pulling wisdom teeth? I mean, what are your thoughts on general dentists doing Invisalign?
I don't really have a problem with it. I think if they're careful with their case selection and they have their clear goals as to what they're trying to accomplish, then, it's perfectly reasonable. It's when they, of course, I see the ones where there's a problem where they're kind of getting in over their head. What surprises me is that they don't ask for help. They're bound and determined to try to push through. And I had a young woman who she came to me on her own. Her dentist was trying to treat her with ClearCorrect, and she was a deep bite class 2 rotated upper canines, which was her chief complaint. He had treated her for 2 years, and she was the canines didn't correct. She was getting ready to get married, so on her own she happened to come to my office, and she told me her story. She said, "I'm getting married this summer." This was like January. And she said, and obviously she'd like to have a pretty smile for her wedding. We went ahead. We were able to get her a nice looking smile before the wedding. We used AccelDent and fixed appliances. I didn't want to, wanted something that I could definitely rotate those canines quickly and predictably.
And you used AccelDent. Talk about that. And a lot of people listening might not know what that is.
Okay, well, the AccelDent is a device. It looks like a mouth guard that they hold between their teeth for 20 minutes a day, and it produces a gentle pulse. It's not uncomfortable, and the idea is that speeds up the tooth movement by up to half. It's supposed to be up to 50% faster, and you can use it with either fixed or aligners. My aligner patients. The normal aligner patients change every 7 days. My AccelDent patients change every 3 to 4 days. And I was just showing, my Invisalign rep was just in here. I have a teenage girl. She was, a typical crowded class 2 on one side. And she finished her treatment in under a year with aligners and the AccelDent.
So how much is, in your office, how much is fixed braces versus how much is Invisalign? And then how much would it cost to add AccelDent, the vibrating mouth guard?
The fixed Invisalign is about the same price. And we add about $1,000 to the overall treatment fee for the AccelDent.
So you're pricing fixed and Invisalign at the same?
Yes.
Do you think the people that are doing only 20% Invisalign and 80% fixed is because they charge more for the Invisalign? Did you raise your fixed ortho fee to match your Invisalign, or did you lower your Invisalign to match your fixed?
I basically matched the Invisalign to the fixed.
So then you're a lower cost provider of Invisalign then?
I guess.
Well, the term I hate the most is the United States of America, because people throw it around all the time. Whereas in Europe, nobody says, I'm from the EU. Nobody would compare Germany to Greece or Denmark to Portugal. And how can you compare Manhattan to Wichita, Kansas? How do you compare Alaska to San Fran. I mean, the United States. So when you're talking about fees, I mean, even the Federal Reserve says that we're about 9 to 11 countries flying under one flag. I mean, you know what I mean? I mean, when oil is $100 a barrel, I mean, Texas, Louisiana, Oklahoma, and North Dakota are exploding. It doesn't matter what the rest of the country does. When oil falls to 20, those 4 states go in reverse. You know what I mean? I mean, it's just so. But I do say, if I had to have an average fee for America, I would say that the Invisalign at the average orthodontist in America is $1,000 more than the fixed. Would you agree with that or disagree with that?
I would not disagree with it. I'm sure there's a lot of orthodontists, they do charge a premium because, you know, we tend to be frugal, and, you know, we have that hefty lab fee that we have to take care of.
And so, what is the lab fee on Invisalign versus fixed? What would you say your fee is on fixed for all the brackets, wires, rubber bands?
Well, it's probably only a couple $100.
You think it's that high? You think it's $200?
It's probably less than that because honestly, I don't do the ordering. I don't. If you were doing one of the more expensive brackets like the Damons or some of those, then it would be up around that. We're probably only paying a couple dollars a bracket, so that's you know, so it's probably, you know, between $100 and $200.
And then what would the lab be on Invisalign?
Well, I do a lot of it, so I get a volume. You know, the more you do, the less more it comes down. So it's a little over $1,000 for me.
$1,000. And then what's the overhead of the AccelDent?
That again, I think we're getting them for about $600 a piece.
And in your mind, you believe it does accelerate the ortho?
Yes, yeah. I have one of my colleagues that says that is telling his patients it doesn't work, and you know the research out there is kind of mixed, but I think there's more and more evidence showing that it does work. And my patients that have been using it, it's working for me. So, you know.
Yeah, I'll tell you what, the press had a field day with flossing because
yeah.
At the end of the day, if you're a research scientist, then you all agree that there's no research that floss works.
Right.
So then the question is, does it work or not? I mean, so when these guys say, I only do evidence-based dentistry, it's like, dude, it's only 2016. That might be something you could say 10,000 years from now. But in 2016, you don't even have research on floss. I mean, so many things we believe are just just intuition or myth or.
We use what we perceive that works, right?
Well, you know, the one thing the AccelDent that made sense to me is like in a fixed, you have all these brackets, you have all these wires, and there's all this tension. You think if you just went in there and vibrated and settled it and just kind of just leveled out all the energies and the arch wire and the brackets, I could see how that could be a game changer. I can imagine, you know, this tooth trying to slide down a wire, but it's just kind of caught up.
Right, it binds. Yeah,
it binds and putting a vibrating force. So I could see. So in my walnut brain, AccelDent on fixed seems obviously clear, but you're saying it accelerates on Invisalign too.
Yeah, and if you think about it, it's kind of jiggling those aligners into the teeth into those aligners. So, yeah, it works. Also, it for the fixed patient, it decreases the discomfort from adjustments.
You know, podcasters are young. When they want to learn something on orthodontics, they'll get on an airplane and fly across the country and drop $3,000 on a course or something like that, because they think that if they came and knocked on your door, you would bite their hand because you would want to do the ortho. So you're talking to a lot of dentists right now, and a lot of them in your area. What would you say to a young kid if they wanted to learn from you? If some young kid walked on your door and said, I want to learn about Invisalign, what would your reaction be to that?
Well, I would say, yeah, I'd be glad to help you. Let me see some of the cases you're thinking about. I'll give you my advice. And, you know, if I do think that it's a little bit ambitious, I'd let you know. But, you know, there's plenty of simple cases out there that are perfectly appropriate for the non-orthodontist.
I know I've always believed that more there's more street smart people working menial jobs than there are in dentistry, medicine, and law. And I think the street smart dentist can learn the most information the cheapest with a textbook. Just go on to Amazon and buy a textbook. It's $100 or $200. That's how much they'll spend every night in a hotel going to some $1,000 seminar. And then the second most street smart thing, because they shouldn't walk over to you and ask you questions that they could have learned in a book. And then the second street smart thing is, if you wanted to learn something about a root canal, why wouldn't you ask the endodontist across the street who wants to know you, wants a relationship, would love to meet you, and knows at the end of the day that if he's your buddy, you're going to refer him the ones you don't want. I mean, to me,
Right.
I just think, God, you shouldn't get on an airplane to go learn any of the specialties in dentistry. You should walk or ride a bicycle.
Sure. Yeah. It's it's a difference between kind of a competitive mindset versus a cooperative type thing.
Yeah, I do agree. Success is a golf game. It's not a boxing match. I mean, when I opened up my dental office, I wanted to meet all the dentists across the street, and I knew my success would depend on my own golf game, not a boxing match with a guy across the street. So, what do you think? Some of these insurance companies. What percent of your practice is insurance driven versus a general dentist? Would you say?
Probably not as much as the general dentist. Honestly, I have no idea what insurance plans I participate with and whatnot. We let people know, we work with whatever insurance company they have. Some of them just aren't worth dealing with, period. We try to let them know that they shouldn't let their insurance company dictate where they get their orthodontic care. So, there is a state insurance. There's one fellow that accepts it, and the care that he has to do high volume and nothing fancy. And I've seen some unfortunate results come out of that some of which I've tried to correct. So, but
yeah, you're either going to be low price and high volume, or you're going to be
right.
low volume and high value. When someone signs up for Invisalign, a lot of their marketing is that, you scan it, you send it in there, and that there's somebody on the other end helping you, coaching you, diagnosing and treatment planning through this case. Would you agree with that or disagree with that?
They do have some products, one called Invisalign Assist, where I think they get more guidance as to how to do the treatment. I just do the straight. I have my technician in Costa Rica sets the case up, and then I make the changes. And there's hardly a tooth I don't touch.
So do you orally scan the impressions, or are you sending in impressions, physical impressions?
I'm using an iTero scanner.
So, and how long have you been using iTero scanner?
I believe we've had it at least 3 years now.
That's the one that Invisalign purchased?
Yes.
And now is it an open format? Does Invisalign work with other scanners?
They do work with at least one other one, but it's one of the scanners that you have to put powder on the teeth, so I've never even looked at that.
For the iTero scanner, you don't have to?
Right. No powder.
And are you always working with the same person in Costa Rica?
I was up until recently. I had Leo, and it was great because Leo, learned how I like to do things. And so lately, just in the past few months, I've started getting, I don't really know who my technician is. And, sometimes I have to explain things a little bit more now. I'm not sure what the deal is there. I need to talk to somebody.
Have you ever gone to Costa Rica?
Yes, actually I have.
To the Invisalign plant?
Yes.
I want to go down there and podcast there. I think that'd be a blast.
Yeah, that'd be awesome. You'd have a great time.
Yeah. Well, hey, I would love to do that. And my one of my best friends from dental school, Craig Steichen, it's like his favorite place to go. He says there's so many Americans down there retiring that it's just a really, really Beautiful place. Let's talk more controversies. There are, whenever you say never, never is a pretty extremist word, but there are a lot of general dentists who, if their orthodontist pulls four bicuspids, they just write him off. I mean, they think he's quack, he's dishing the face, he's a molar mechanic on the bite, and he doesn't realize what it's doing to her profile.
Yeah.
And obviously, there's cases where if you did not do premolar extraction and you'd extrude the teeth out of the out of the ridge. Well, what would you say to someone listening to you right now? Because they're, let me say it another way. When you go to state meetings from the CDA, from Chicago Midwinter, the ADA in Denver, they, of all the specialists, endodontists are speaking to general dentist, oral surgeons are talking to general, every specialty is there educating the general dentist, but the orthodontists are a no-show. Do you agree with that or disagree?
It doesn't surprise me.
They are. They're a flat-out no-show, and they're the biggest specialty. If you cut them in half, each half would be bigger than the second largest specialty, which is 5,000 oral surgeons. So since you have a culture where the orthodontists don't lecture to general dentists, then they're listening to general dentists. And some of these general dentists, they're, remember when Witzig would go over to Europe and he'd come back and he'd say all this stuff, and all the orthodontists would say, that guy's nuts. And it's like, well, at least he's saying something. He's got a room full of 100 dentists. You're at home in your closet. So rant about extractions, because I know my homies well. I mean, I've known them for 29 years, and a lot of them are extremists against 4 bicuspid extraction. What percent of your cases are 4 by extraction?
Oh, maybe 20%.
And what do you think it was when we were little and just got out of school?
Oh, it's probably more like 80%.
yeah, and that's so it overcorrected. So it was obviously way too much back in the day.
Yes.
And then some people want to swing that pendulum all the way to 0.
Right.
And you're saying that it's probably based on your Maryland ethnic people, it's about 20%.
Yeah, I probably don't take out as many teeth as some of my colleagues. I tell you, this is something that I've always had an interest in. Edward Angle, our father in modern orthodontics, he was extremely non-extraction. He did not believe in extractions. And that's what he taught all of his students. Charlie Tweed, down in Texas, he noticed that he didn't like the aesthetics that he was getting, and he was having a lot of relapse. So he retreated, I think, 40 of these patients with removal of 4 bicuspids, and then he presented that at a meeting. So, and that kind of started a trend towards extractions. And, all the way through the 60s and the 70s, a lot of premolars were removed, me included. and one of the thoughts was that it was going to be more stable, because they felt like expansion and so forth was not a stable procedure. Well, they did more studies. They found that crowding the lower incisors happened whether you took bicuspids out or not. So it wasn't more stable. So of course, the answer is not all one or the other, as it is with a lot of things. It's somewhere in the middle. So there are cases where you need to extract some teeth, and cases where you don't. You have to do a proper diagnosis and determine where you want the teeth in the profile. If I have somebody that's arches are constricted, they may have a lot of crowding, but I figure by the time I get more of a normal arch form, I'm not going to have so much crowding. And then there's other cases where I'll tell people, look, you're kind of borderline. I can certainly straighten your teeth up, but it's going to depend on whether or not how your lips are going to look when I get done. If I get your teeth lined up, but they're leaning out so much, you've got the eating corn through a picket fence look, and you can't close your lips comfortably, that's not going to look good. So a lot of times I'll say, this is going to be a waffle. We're going to kind of see how things play out. I said I can take them out later. I can't put them back. So, That's my kind of my philosophy.
So when it comes to ethics and morals, when that girl told you she was trying to get her teeth straightened in 6 months before her marriage,
Right.
wouldn't that have been a good time to just tell her that this was God's way of telling her not to get married and just save her all that headache?
I'm not a marriage counselor, Howard.
So let's talk about when braces are done with retention, fixed versus Invisalign. Talk about retention in general. What type of relapse do you see in a general population as an orthodontist for decades like yourself? And what type of retention do you like after? I mean, talk about retention. Rant about retention.
Okay, so retention's a fact of life. I heard somebody say that he would give half of the treatment fee if somebody else would just take responsibility for the retention.
Yeah.
Because, well, for one thing, a lot of people don't realize is that teeth have a tendency to shift as we age, particularly lower incisors. They like to crack, particularly in Caucasians of Northern European ancestry. So that's one thing we have to deal with.
Well, let me ask this. When you're done with fixed, you have to make them either a retainer or fix a lingual bar,
right,
for the most part. Is it the same with Invisalign, or do you just
yeah,
leave them on their last tray?
No, I use my same retainer protocol for my Invisalign patients as I do for my fixed patients.
And what is your protocol? Upper and lower retainer? Then
I use a clear removable retainer on the top, and on young people, I use a fixed lower canine to canine wire. If they're an adult, I typically use removable ones, top and bottom. And my only reasoning behind that is I figure the adults are more likely to wear the retainer. The teenagers, they can get busy, they forget. The bottom, those lower teeth are the most susceptible to moving.
Do you believe that interproximal sanding and taking instead of two eggs trying to retain each other, two square blocks, do you think interproximal sanding to make it a more two square edges touching each other helps with retention, or not really?
I've heard that. I do a lot of interproximal reduction, not to square the edges up. I still try to maintain basically normal anatomy of the teeth. I've never seen any research as to whether or not having two square surfaces is more stable than rounded ones. You would think that it would probably be a little more stable, but there's so many factors in why teeth shift. There's a buzzword in orthodontics about things being stable or not, and that's where the people who like to take teeth out, they think that they're putting the teeth in a more stable position. And I've been thinking about this lately. The most stable position is the original malocclusion. If you don't touch them, they're going to tend to want to stay there. So anything you do, it's going to tend to want to come back a little bit. So that's one of the things you have to look at. One thing we probably don't do enough of is look at the original malocclusion and do a little bit of overcorrecting to help account for that. There's a orthodontist from I think it's either Sweden or Norway, Dr. Bjorn Zackerson, who's a phenomenal clinician, and he's done some really amazing work. But he gave a lecture called 11/10 correction. And he said, and that's what he talked about, doing a little bit of overcorrecting, teeth that have a little bit of rotation. You overcorrect it just a tad, overcorrected. Deep bites, you want to open them up more. Open bites, you want to close, finish them a little deeper. And, because most of the time what we do is 9/10 correction. We correct them most of the way, but, if you looked at where they started, and there's still just a little bit of a hint of that rotation of that incisor or whatever.
So you said when you and I were little and got out of school, it was 80% 4x extraction. Now it's 20%. talk about headgear versus implants. For what do you think's happened to headgear from 30 years ago to now?
We have a joke about headgear. Orthodontists say, I use headgear, but my patients don't. I think there's still guys out there that use headgear. Maybe they're more persuasive about getting their patients to wear it, but the active teenager today, getting them to wear that headgear for 12 to 14 hours a day, that's a tough job. That's a tough sell to do that. So I use a Herbst appliance for my class 2 correction. There's a lot of stuff being done with the temporary anchorage devices. And some of the things, I think it's a technique that is being a little overused. I think I see some case reports in the journals where they used a TAD, and I'm thinking, I really don't think they needed the TAD. You could have done this just as easily, got an equally good result without the TAD.
As far as I can tell, in all of America, really, all of North America, there's only one board-certified orthodontist who teaches general dentist ortho, and that's Richard Litt. He used to run the program at UCSF, University of California, San Francisco. Then he's over at Detroit. I see him, I don't know if it's a marketing or whatever, but he hardly, he's not that popular. I went through his program. I loved it. It seems like the majority of general dentists, they go learn short-term ortho. The market killers are like Power Procs, 6-month smiles. What is your thoughts on short-term ortho and these courses in particular, like Power Procs and 6-month smiles?
I'm not familiar with the Power Procs. I know the 6-month smiles. I'm I'm one of Jay Geyer's clients with the Scheduling Institute, and
I did not know that.
Yeah, and so he has an awful lot of general dentists in there, and a lot of them do 6-month smiles, but I think a lot of them they're moving away from it and doing more. I think most of them are hiring an orthodontist to come into their office now and letting them do it.
Yeah, I always, it seems to me it seems like didactically you should go to Richard Litt and learn full ortho first.
Right.
Before you would go and say, okay, I'll just do the easy case. I mean, I think it's, to avoid trouble. Jay Geyer, that was kind of funny. I went to Creighton, and one of my friends there, Tom Mattern, who's now a dentist across the street from me, known him forever. For like 4 years, he kept telling me, "Dude, you got to do Jay Geyer. You got to do the Scheduling Institute." And I'm just whatever. And he must have told me 20 times. I finally did that, and it was a game changer for my front desk. I mean, to start recording the front desk phone calls and to have a trainer come in, once a month on a Saturday for 2 or 3 hours and go over these recorded voicemails. And I would sit there and these girls that I love who've been with me 10, 20, 30 years, love them. And they know more about everything than I do. And you'd be listening to some of their phone calls and you're like, you got to be kidding me. What the hell would you say that for? And these dentists that sit back in their office doing their root canal, who think little Betty Sue up there is the best person to answer the phone. Hell, her job position is named after a piece of furniture, front desk. They have no training. They didn't go to school like the hygienist or the dentist. And I thought Jay Geyer, I thought that was basically, I believe that it takes 3 strangers to call your office for one to get scheduled in the chair. And they can turn that to maybe 1 out of 2.
Right.
What is your experience with it?
Well, we've been a client of his since 2012, and we've grown a ton. I mean, it's hard to get to change those habits, and but we just keep on plugging at it. We get the trainers come in here periodically and do their thing. And
so, what are they mostly training? The people scheduling, the people answering the phone.
Mostly, yeah.
And they're
I have my whole staff sit through the phone training, and then when they also do like the new patient experience and case presentations, that kind of thing.
So you thought it was a return on investment?
Oh yeah.
Oh my God, Jay Geyer's gonna love you.
It's funny. I just met with my accountant, and my accountant was concerned with all the money we've been spending, on trainings and all that stuff. And then she just said, I thought you were spending a lot of money, but it's, you're getting a return on your investment. So
Yeah. Yeah, I mean, nobody would consider hiring a hygienist without any training.
right,
Nobody would consider getting a dental associate that didn't go to dental school and just say, "Well, I'll teach you."
yeah,
And then they have an opening at the front desk, and they just hire Mary because she was just a lovely lady. And there
right,
you go. Go take it.
yeah. Answer the phone.
Yeah, answer the phone. You're named after a desk, and wow, yeah, to get them trained. I mean, and the other thing do you feel like you don't have to do this forever? I mean, will you eventually stop the scheduling suit, or you just keep on year after year?
Well, I don't know. I figured we'd do it for a couple of years, but we're still getting some benefit out of it right now. So yeah, we're continuing that. We're getting ready to open a satellite and move into another office. So we're still going to need the trainers. I like having access to the trainers.
So I'm gonna see just how old you are right now with this next question. When everybody's talking about corporate dentistry, they're talking about Heartland and they're talking about Pacific and Aspen, all these chains. But you and we remember the first big DSO was Orthodontic Centers of America.
Right.
And it made it all the way, the only one to this day that made it to the New York Stock Exchange and had a $1 billion valuation, and then it fabulously imploded. And what do you talk about what you know of that story? What do you remember that story?
Well, I remember that they were behind opening up some of these other programs, like the one at Jacksonville, the orthodontic program at Jacksonville, and they
Colorado.
Right, in Colorado, and was it Las Vegas too? Did they do that program?
I think so.
Yeah. Okay. So they opened up these programs, a whole bunch of residents in there, and the deal was they would get a job with an Orthodontic Centers of America clinic when they got done, and then when they went out of business, these guys were left hanging out to dry. And honestly, I don't really recall exactly what caused them to fail. Was it it was when the economy turned crappy? Frankly, I don't recall why exactly things
well,
went sour.
To me, from my humble opinion, it looks like history always repeats itself. When I got out of school, Orthodontic Centers of America was every orthodontist in America was afraid that they were going to be taken over like Walgreens, and right. They all feared it. And there was a dozen DSOs on NASDAQ. They all imploded, and then the lessons forgot for a decade, and now they're back. And this time, Wall Street's smarter because you don't see Wall Street taking any of these boys public.
Right.
I mean, if it was some profitable business growing on earnings, everybody on NASDAQ could be knocking on their door saying, "Let's do an IPO." You don't see one of them on getting an IPO. You don't see one of them on NASDAQ. So Wall Street didn't forget. What I saw it as a liquidity play. There's all these orthodontists that had these practices that were doing 2, 3, 4 million a year, and there's no way they're going to sell these things. And some Wall Street boy, Lazarus, went and got $100 million line of credit and just started buying up all these offices. And that's what I see most DSOs, how they grow. They grow every dollar they grow in revenue, they grow $1 in debt. That's not a very sexy balance sheet. Right. I doubled my sales. Yeah, now you're in twice as much debt. Oh, I quadrupled my sales. Now you quadrupled your debt. I mean, by the time you get to $1 billion a year in sales, you got $1 billion of debt. That's not sexy. No one on NASDAQ wants that. And then when they bought you, they said, "Okay, James Crouse, you have to stay here for 3 years and 1 day." Right. And then that 3 years and 1 day, James said, "I am out of here. I'm going to jump on my Harley and fly down the road." And then they replace you with some punk-ass kid straight out of school. And, yeah. I mean, you just don't realize what you learn. I mean, could a guy walk out of dental school and just you leave and you just hand him the key and they could just run it? Same thing.
No, no, it'd be a disaster.
Yeah. Okay, exactly. So nothing else needs to be said. If you're a Wall Street broker, I get so many emails, especially on LinkedIn, from all these analysts and Wall Street brokers, and they always want to know the story. And I mean, I've explained it so many times. You just don't know. I mean, how many years you been doing this?
Oh, 25.
How long would it take if Mary Lou just graduated from orthodontic school on Friday? How long would it take her to ramp up to be able to run your show? Same numbers, same staff, same starts.
I think I saw some studies saying that it takes like 7 years.
I know. So anyway, crazy. So what would you say to a kid who's listening to you and says, "Well, I want to get into ortho, and I think I'm going to sign up for this 6-month Smiles or this Power Prox or short-term ortho"? What would you say to them?
I would say that, again, it's case selection. You have some specific goals that you want to correct on a person. You're not worried about their posterior occlusion. And, that person wants their front teeth straighter, then, go ahead and do it. But, it's nice if you run into problems, don't be afraid to, ask your friendly neighborhood orthodontist for some help or some advice. I've got friends of mine that, a good friend of mine, he was trying to treat somebody with some clear correct, had some lower incisors that just would not correct. And I went ahead and fixed it for him. I didn't charge the patient. I just put some brackets on her and got her done and made her happy.
Let's try to focus the remainder of this on young general dentists who are seeing patients today that have stressed out problems. One of them that's always stressing her out. She just graduated from school a year ago. Mom's in the chair saying, little Billy keeps sucking his thumb and it looks like it's fraying his teeth. When does this have to stop? When does she need to tell Mom, look, it can't happen anymore. You got to put a sock over his hand. You got to do a retainer. Talk about thumb sucking.
Okay, well, the most important thing when it comes to a thumb sucker is the thumb sucker has to be ready to stop. If they're not ready to stop...
Are you talking about smoking and drinking or thumb sucking?
They're the same thing. It's easier to quit smoking than it is to stop sucking their thumb.
I had 4 boys. One of them sucked his thumb. I'm not going to say which one. I won't embarrass him. I could go in his room and grab his wrist to pull his thumb out of his mouth and lift him off the bed. I mean, yeah. It's like the shoulder would have came out before the thumb would have come out.
Yeah. And I try to explain that to parents when they come in. They come in and I try to talk to the kid. I say, let's talk about your thumb habit. And, well, first of all, I ask them when they do it. If they only do it when no one else is around, in the evening, that's a good sign. If they do it anywhere, they do it in school, they do it in front of their friends, they do not care. That you've got a serious problem. You got to turn them around. And so a lot of times I'll have them come in on a recall basis and I'll talk to them about it and try to talk to them about what it's doing to their teeth and so forth until they get to the point where they're ready to stop. Sometimes, mom or dad harping on them doesn't help any. It just increases their stress level and they want to do it more.
Hey, don't say that very loud. Ryan's sitting right next to me. I don't want him to hear any of this nonsense.
So sometimes it takes the authority in the white coat to tell them that they're causing problems, and they'll stop.
But when does it have to stop before it's caused an orthodontic issue where you just condemn this to full ortho? If
you can get them to stop before their incisors are fully erupted, it helps a lot.
So you're talking, what is that, 6?
Yeah, around 5 or 6 is good. And a lot of the problems, like an open bite, if you get them to stop, that'll self-correct a lot of times. The only thing they won't correct is if they have a posterior cross bite. That's going to stay unless you fix it.
Okay, that's my next question. At what point when, okay, she's doing an exam, it's a child, it's got a crossbite. When does this need rapid palatal expander? Is this something that needs, would you prefer done at age 2, 3, 4? When should she say this needs to be corrected?
Well, the American Association of Orthodontists recommends that kids get an ortho eval when they're 7. And that's because the first year, the 6-year molars are in, and the incisors, most of them are in. And if they have a crossbite, particularly if they have a shift, functional shift, then we go ahead and we correct it then. And lately, we are doing more as far as expanding kids with really narrow arches if I suspect that they have airway issues. So, there's a lot of more attention being paid to airway, both with adults with sleep apnea and with kids with sleep disturbed breathing. So rather than, before, if their arches were narrow, they had some crowding, but they didn't have any cross bites, I just recommend taking some primary teeth out. But now the trend is going to expanding both the upper and lower arches. So that's what I've been doing lately.
One last question on Invisalign. What did you think of the controversy? There's a company, SmileDirectClub, that's going straight to the consumer, bypassing the orthodontist, and Invisalign said we'll make the trays for them. What do you think of them bypassing you, going straight to the consumer with Invisalign?
Well, it really pissed a lot of my colleagues off, understandably. It seems like such a tremendously bad idea. And I don't know. We'll see what happens there. Invisalign says they're doing it just so they can have, they say it's coming regardless, and so they felt like they could have some kind of control by doing what they're doing.
I would imagine it's hard to know exactly what's going on, because didn't it start first with Invisalign suing them because they were infringing on their patents?
I don't know, but I wouldn't be surprised.
I thought it started out as a lawsuit, and then when they came out of the courtroom, they were married. That might be an oversimplification. So my last question, and by the way, I'm sorry, I went over 1 hour. Can I ask you an overtime question, or do you got to run to a patient right now?
No, I'm at your disposal.
Okay, so this is the I'm saving the craziest question for last. If I lined up 100 endodontists, they almost wouldn't have any arguments with each other. If I lined up 100 implantologists, they almost wouldn't argue with anybody. When you start talking about occlusion, you have Christians and Catholics and Mormons and Scientologists and Hindus and Buddha. It's batshit crazy. When I listen to 5 dentists sitting around a table, drinking beers and eating cheeseburgers, talking about occlusion, I don't know whether I should laugh or cry. I mean, and so many of them do not like their orthodontist, because the orthodontist has blown away the curve of speed, the Wilson, taking them from canine guidance to group function, and they could rant for 8 hours at how you ruined everything. So my thought is, do you agree with that assessment or not? Is occlusion like that? Is it like religion?
Yeah, it's like it's an inexact science, let's say. And orthodontics is like that too. I mean, there's so many different ways that you can treat somebody, as we talked about: extraction, non-extraction, surgery, non-surgery. It's the Wild West. It's Deadwood in 1876. There's no law. There's no laws in orthodontics.
What percent of these American kids walk into the 10,000 orthodontists in America in canine guidance and leave 2 years later in group function?
Well, that's a really good question too. And we get, when we finish their treatment, we take the braces off. There's a period of settling. Things change. You probably really don't know the true occlusion for at least a month after you've gotten them out of their appliances. And honestly, we're busy. We get them in. there's not a lot of us that are really critically looking at that occlusion, getting out them articulating paper, having them go into the excursive functions and see what's going on there. I have a T-scan. Are you familiar with that thing?
Yeah, absolutely.
And I'm seriously considering, especially in my adults, T-scanning them when I get done, and doing a little bit of a occlusal adjustment and try to really fine-tune that occlusion.
Those are the and that speaks even more how divisive the occlusal community. That's more of the dentists that do that are more into neuromuscular occlusion.
Right.
And they use the TEC scan, the T scan, and they differentiate themselves very much from the others like Dawson, Coy, Spear, who they would say are CR people. And and if you ever had the opportunity to sit between two of them at a bar, that's that's quite an interesting conversation. I'll never forget one time I was flying back from D.C. You can't make this up. I was flying back from Washington, D.C. to Phoenix, Arizona. It's a 3-hour flight, about 3.5, maybe 4. And I'm sitting in the middle seat between two rabbis. And they're arguing for 3.5 hours about this one writing on this one clay pot from 500 BC to King David. And I mean, it's like, it was just amazing. I mean, I would just say, I didn't say a thing, just listening to how intense. And I was wondering, how much of this is just, at the end of the day, you have to pull something out of a hat. I mean, unless you can talk to the guy who scribbled that on a clay pot, I don't think we're going to really, I don't think we can go back and know what he said. But, man, I just think you're fabulous. Are you, if you're a top 1% provider, do you have any connections upstairs at Invisalign?
No, not really. I think I have a pretty good relationship with them. They just recently changed the CEO of the company a couple years ago. So
is he in San Fran?
I think so. Yeah, Cupertino, or that's Apple, but around San Jose in that area. I think.
Silicon Valley.
Yeah.
Yeah. All righty. Well, I wish someone would do an online C course on Dental Town for Invisalign. Maybe you should do that. Maybe.
I'll keep it in mind, Howard.
Yeah, and you know what? All the specialists who put on an online CE course said it was the best thing they ever did for their referrals. They
really?
Oh yeah. I mean, I got specialists like oral surgeons and stuff that put up an online CE course, and they didn't realize. I mean, Dental Town's huge. It's 250,000 dentists, and then all these general dentists pop up out of nowhere and say, I met you on Dental Town. I took your course on Dental Town. I mean, I got specialists that, they mostly are the only ones motivated to create online CE because of what it does for their general dentist referrals. They just said they just didn't know how many townies there were out in the middle of nowhere in the woods popping up. Because the people that are going to see it, I mean, you figure a quarter of all the dentists in your state are going to see this thing, and so that might be the first time they've ever met you or listened to you talk for an hour or whatever. But
yeah, okay.
So the old
That's currency,
the old currency for marketing when we were little was pay. You bought the big TV ads on ABC, NBC, CBS. But today, the number one currency for advertising is time. You share your time.
Sure.
Post on message boards, create CE, do a podcast, but you can't buy your way to the top like the big brands could in the 70s.
Right.
The new currency is sharing. But man, I think the world of you. I think the world of your wife. I think your wife is your secret mojo, Sharon. I mean, God dang, she just eats, lives, breathes, and dies and sleeps your office, doesn't she?
Pretty much, yeah. Yeah, she's pretty passionate about it.
Yeah, so you did very, very well there. But hey, thank you so much for spending an hour today with me and my homies. I found this to be very fun and informative.
I enjoyed it, Howard. Thank you very much.
All right, and you're sitting there making me feel extra bald today, knowing that you're going to leave with a ponytail and get on a Harley, and I'm some bald guy getting in an SUV. I need to trade places with you.
All right. You know my advice.
Have a great day, buddy.
Thanks, Howard. You too.